I'm Alexa Kane, the Executive Director of the Melanoma Network of Canada. We are pleased to offer this informative webinar on the advances in treatments for uveal melanoma patients, presented by leading medical experts. Uveal is a rare and frightening disease. There is not a lot of information on this disease for patients, and so they feel very desperate and often isolated. Our mission at the Melanoma Network of Canada is to support uveal patients. Those living have been changed by this diagnosis. MNC is a leading national voice for patients advocating for drug therapies for early detection and improved treatment access. For the past 10 years, Melanoma Network of Canada has been delivering valuable patient resources, support groups, publications, information sessions, and educational webinars such as this one. Through today's webinar, we'd like to provide all listeners with a support network and share valuable information to close any gaps of uncertainty that patients may be feeling with a uveal melanoma diagnosis. And now I'd like to introduce our first speaker. Dr. Krema is a leading ophthalmologist with Princess Margaret Cancer Centre and University Health Network and University of Toronto. Dr. Krema is an associate professor in the Department of Ophthalmology and Vision Science in University of Toronto. He's interested in translational clinical research in the field of ophthalmology oncology. His focus is defining better algorithms for radiotherapy in ocular and cancers, management of treatment complications, introduction of innovative surgical techniques, and modern auxiliary diagnostic imaging, and the role of molecular genomics in defining patients at risk of metastatic disease. He's been entitled the Honorary Fellow of International Council of Ophthalmology in 2017. He has been invited as a guest speaker in several national and international conferences, and he is a frequent presenter and moderator in international ophthalmology meetings and has published over 150 papers for consumption. Welcome, Dr. Krema.
Thank you very much for the introduction. Thanks for everybody attending the webinar. As presented, I work in the field of ophthalmic oncology at Princess Margaret Hospital, and I deal with a large number of cases referred to us from all over Canada. I have no financial interests. To start, because I know that this is addressed to lots of our listeners today are patients and their families, I'd like to go a little bit basic. Uvea that we are talking about here is the tissue in the middle layer of the eye. The eye surface from outside is called the sclera. That's the white of the eye that we see from outside. The inner lining of the eye is the retina, and sandwiched in between is the layer that we can see here on the right-hand diagram in red color. This is the uvea. Uvea is a tract that's represented at the front by the iris, which we can all see has the color of the eye. And behind that, there is a thickened area we call the ciliary body. And the rest of it around the eye is called the choroid. So basically, uvea is the combination of the three. And it's important to know about these structures beforehand because we're going to mention them as we go. Uveal melanoma. Melanoma is a tumor, a cancer of melanocytes that reside in the uveal tract. It grows, as we see, as a lump, which we can see on the surface of the iris or arising from the ciliary body just behind the iris, or in the back of the eye in the choroid. Choroidal melanoma is by far the commonest, representing 85% of the cases. Ciliary body is 10%, and iris melanoma is just 5%. It's important to understand that uveal melanoma behaves differently from skin or ocular surface melanoma. They are both arising from melanocytes, but they have different natural history and different genes that control them, different courses. So uveal melanoma has so far no clear relationship to ultraviolet rays in comparison to skin melanoma, which has strong relationship to ultraviolet exposure. Uveal melanoma, if it metastasizes, it goes to the liver primarily, less likely to the lung and other tissues, but Skin melanoma or conjunctival melanoma at the surface of the eye metastatizes to the local lymph nodes and to the brain. Also, the driver genes that control the growth and metastasis in both types of melanoma are different. So it's important when we go on the internet to search for ocular melanoma not to confuse surface melanoma from uveal melanoma. I have some few facts to know about uveal melanoma. It's the most common primary intraocular cancer in adults. It's yet rare. It's just 6 per million of population per year. So in Canada would be like 220, 230 patients per year, all in all, of uveal melanoma. It peaks around the age of between 50 to 70, but cases have been reported even in early childhood. It's rare in dark skin races, and it has no sex predilection. It's not hereditary except for the rare cases that carry the germline BAP1 mutation that we're going to speak about later on. It comes as one cancer in one eye, luckily or unluckily. It's unilateral unifocal tumor, and the symptoms the patient feels related to where it is located in the eye. So if it's near the central structures that serve vision, as we see in the picture here, the dark dot here is what we call it the macula, which is a central part of vision, and the tumor is encroaching on it. It will give blurring of vision or distorted vision. If it's located in the corner of the eye, the patient might not notice anything or just some flashes or floaters, and in that case it will be detected by his ophthalmologist when he go for dilated eye exam. As we mentioned, if it metastatizes, it goes to the liver, less likely the lung, the gastrointestinal tract, skin, and bones. The risk of metastasis depends on the development of certain gene mutations in tumor cells. Tumor, as it starts, not metastasizing, might not be metastatizing from day one, but as it keeps growing, it acquires some gene mutation that makes it capable to makes the cells capable of leaving the mother tumor and metastasize outside the eye. And to know if the tumor has acquired these gene mutation, we do what we call genetic testing. To diagnose uveal melanoma, we do not normally take a biopsy. We depend on clinical means. We're lucky that we can see the devil on his face directly. It's not hiding under the skin like other cancers in the body that we need to take a biopsy. So when you go to your ophthalmologist, they can tell you right away that this is a melanoma or not based on the clinical findings. We have cameras to monitor the tumor, whether it's on the surface of the eye, the back of the eye, can measure the base of the tumor. We can also measure the thickness of the tumor inside the eye by ultrasonography. We can tell from the ultrasonography criteria, are we dealing with a melanoma or even a blood clot or something otherwise. So we have identified clinical features that help us to diagnose without really the need to resort to a biopsy for diagnosis. As you see, we can do angiography also to study the tumor vessels to tell that this is a melanoma versus a retinal hemorrhage or otherwise. So how do we treat uveal melanoma? We have several options. We have radiation therapy, which can be applied directly to the eyeball, what we call it brachytherapy, or irradiation to the eyeball from a distance, what we call it teletherapy. We can also remove the eye completely in advanced cases, and we'll come to that. There is a small role for laser, and there are few indications that we have to resect the tumor off the eye. There is no role for chemotherapy, however, currently for treatment of the uveal melanoma in the eye. So brachytherapy is the current standard treatment for most intraocular uveal melanoma. It's an applicator that's gold shielded, so the radiation does not emit to the outside of the eye, and it's all directed to the inside. And we fill it with radioactive seeds. We use a computer software to calculate the dose required to kill each tumor according to its dimensions. The plug is inserted and fixed in place under general anesthesia under the base of the tumor, and we leave it to hit the tumor with radiation for 5 to 7 days, and this is calculated to destroy the tumor DNA. We fix it with sutures on the eye, and most of the people tolerate the plaque on their eye during the 6 days without big pain. And the way it works is that the radiation comes out from the plaque and covers the tumor without causing much radiation damage to the structures around. And this gives the maximum tumor treatment with minimum collateral damage to the eye structure. So most of the patients can still keep their eye and presumably some good sight. And it's successful in killing the tumor in most of the studies, around 93 to 95% at 5 years. The other form of radiation, as I mentioned, is external radiation. For those patients who cannot go under general anesthesia for plaque radiotherapy, we can use external irradiation. In that case, the patient is subjected to radiation on 5 consecutive days, and a plan is put to deliver the radiation to the tumor. However, it's not as focused as the radiation from the plaque. So we expect some more collateral damage with external radiation than we see with the plaque radiotherapy. There is one indication when the tumor is just located over the optic nerve that we cannot really cover the whole base with a plaque. In that case, we need to use external irradiation. Enucleation, which is removal of the eye, is indicated when the tumor is very large. Like there are limits to use radiotherapy to tumor up to a height maybe of 11 or 12 millimeter within the eye. Mind you, the eyeball diameter is 24. So a tumor filling more than 50 or 60% of the eye cavity, if we treat with radiation, it will be a big dose for the eye walls, and it ends up with destruction to the eye itself. So in that case, enucleation might be a better option. In case also if the radiotherapy failed and we have an aggressive recurrence, we can remove the eye. Or if after radiation, some of the cases go into pressure rise or complications from hefty dose of radiation, what we call radiation toxicity, in that case, we remove the eye. So one patient might ask, why don't we take the eye in all cases? So a study called the Collaborative Ocular Melanoma Study was conducted 20 years ago and addressed that question and showed that there is no statistically significant difference in survival between patients treated with radiation and enucleation. So taking the eye out does not guarantee that it would give better survival than burning the tumor with radiotherapy. In case if we have a small tumor at the front of the eyeball and the patient is unable to go under general anesthesia, and also we cannot use external beam irradiation to the front of the eye because it burns the surface structure of the eye, in that case we can do tumor resection, which is a procedure that we create like a flap door on the eye wall and mark our tumor and cut it out and close the flap. We do not like to use this procedure unless it's indicated, because we might leave tumor cells behind us or it can induce significant hemorrhage. We prefer plaque radiotherapy whenever possible. Last, for small tumors or after radiotherapy, if we have like a small edge recurrence, we can still use laser energy, but we cannot count on it for treatment of an entire tumor. So we are good we have several weapons to attack melanoma in the eye, but our concern always is, has this tumor before we treated it started to spread outside the eye or not? By the end of the radiation treatment course, the patient is supposedly left with a heap of dead cells that's incapable to spread outside. But our question is that, has it started before we see the patient? So which tumor is gonna metastatize and which is not? So that was a question, and it was addressed for the first time by the Collaborative Ocular Melanoma Study. As I mentioned, that was a large study, included 50 centers around North America, including the one that I'm working in. And they found a correlation between possibility of spread, or it was translated by that time as tumor-related mortality, and the size of the tumor. The tumors in that study were classified into 3 sizes: small, medium, large, and they looked at the outcome in 5 years, and they found that treated small tumors had much better survival than treated large tumors. So that was like a first rough estimation of prognosis based on size of the tumor. Later on came the TNM cancer staging. That's a prognostication algorithm also based on clinical findings, meaning the size and the location of the tumor without any tumor data taken from the cell of the tumor, from the cells of the tumor. And the data were collected from multiple centers, and it's being updated periodically. So the way it works is that it combines the size of the base of the tumor and the thickness to assign a T value, and then it looks if there are ciliary body involvement, which is a risk for metastasis, or if the tumor started to erode through the wall of the eye to the outside, that's another risk, and assign letter for these. And look at also at the status of the regional lymph nodes and if there is distant metastasis at the time of the diagnosis, and stratify the tumor into 7 stages, 7 categories, and give an estimation of 10-year survival. So again, the smaller the tumor, the better the outcome, the less, no involvement of the ciliary body, no erosion outside the eye. These are all good indicators, and the survival is better. About 20 years ago, a study was published by a German group that for the first time looked at the changes that happen at the cellular level that might be implicated in metastasis. They found that the loss of chromosome 3 in the tumor cells is associated with metastasis in 50% of the cases that they studied, and that was after 5 years. While all the patients that they looked at their chromosomes in the cells of their tumors that were intact, they had 100% survival. That's what we call it monosomy 3, loss of chromosome 3. The chromosomes in our body are arranged in pairs. We receive one from each parent, and they are arranged in pairs. So in pair 3, if you lose one of them, it increases significantly the risk of metastasis from the tumor. And that's a mutation that happened within the tumor. I do not say that it's in the whole body of the patient. So the sample is taken from the tumor. Later on, we started to identify key driver genes on the chromosome. We do not look at the entire chromosome, but we look at specific genes. So we identified genes like GNAQ and GNA11 related to early growth of the tumor, BAP1, which is related to early metastasis. There is a tumor on X chromosome which carries good prognosis, and the mutation of it carries good prognosis, and the gene SB3F1, which is associated with late metastasis. So we started not only to look at chromosome, we look also at specific genes. The next generation sequencing is a method that allows for simultaneous detection of gene mutation in multiple genes at the same time. And there is available now the ocular melanoma panel that can look at several genes of melanoma, including the uveal melanoma driver genes, to tell us about the status of the tumor. To obtain the biopsy for genetic testing, we use and we actually developed reproducible and safe techniques to take the biopsy from the eye without spreading tumor cells outside the eye. And also, we encouraged to take the biopsy from the base of the tumor, so the hole that we create to take the biopsy will be covered by the radioactive plug so nothing can leak outside the eye during the plaque radiotherapy. The value that we get from the genetic testing is important. It provides an individualized estimation of the metastatic risk to the patient and his family for life planning. Also, it modifies the follow-ups. After we treat the eye, what are we going to do next? How often do we need to see the patient? It all depends on how risky his tumor is, so that when we get the individualized information about this particular patient, we can stratify the risk and modify the follow-up frequency and what we do depending on that. The earliest detection of metastasis also enabled the patient to be enrolled in a clinical trial than when it's too late to do any form of interference. So it provides valuable information to the patient and his family, and to the treating doctors as well. One might say, why do we do it, since we have the stratification based on clinical findings like the TNM staging? We have 7 stages. I would say, well, my tumor is this size, this is my 10-year survival, so I know. We not infrequent, we face cases like this. So here I brought you 2 patients. They have tumors almost same size, and the patient's almost same age and same thickness, same location, more or less alike tumors. So both of them, according to the clinical classification, the TNM classification, they fall into stage 2B. But the genetic testing is completely different. One is disomy 3 and one is monosomy 3, like lost the chromosome 3, so he's at risk of metastasis with 8q gain. So according to the clinical classification, they should have the same 10-year survival, which is 68% in this case. But adding the genetic information, which is what we call the Liverpool survivorship scheme that lumps the clinical plus the genetic testing, it sways the prognosis completely different between the 2 patients. One improves to 83% and the other goes down to 20% at 10 years. So that's the value of the genetic testing. It adds individualized information about the behavior of tumor over a long time that we cannot get from just the clinical findings. So based on that, we divide our patients into higher risk tumors, those that have the gene mutation or the chromosomal anomalies associated with high risk. And these we refer to our colleagues, the medical oncologists, to follow the patients. They order MRIs every 3 to 4 months, maybe for 4 or 5 years or more. And there are the low risk small tumors with good genetic testing that we do not need to subject them to frequent MRIs, and they can be followed by us, the ophthalmologists. So to summarize, uveal melanoma is diagnosed mostly clinically. The treatment depends on the tumor size and location. The standard treatment currently is using plaque radiotherapy, which offers around 95% tumor control rate. Tumor genetic testing provides vital information to the patient and his family about the personal risk of developing metastasis. After we finish with the ocular treatment, the frequency and the type of tests that we need and follow-up visits are modified according to the metastatic risk as dictated by the genetic testing. And the patients who are found to be at risk with the genetic testing are followed by the medical oncology clinic to detect metastasis at its earliest stage, then direct the patient to the most suitable treatment or whatever clinical trial available. Thank you very much for listening.
Thank you, Dr. Krema. Our next speaker is Dr. Butler. Dr. Butler is a physician investigator with an interest in translational development of immuno-based therapies for cancer patients. He joined the Department of Medical Oncology and Hematology at Princess Margaret Cancer Center in 2012 and is an assistant professor at the University of Toronto. He cares for patients with melanoma and genealogic malignancies and is the director of Princess Margaret Immune Monitoring Laboratory. His work focuses on the development of immunotherapy trials, which includes studies alone and in combination of immunocheckpoint blocking antibodies, immunomodulators, and adoptive cell transfer. Welcome, Dr. Butler.
Hi, thanks very much for the opportunity to speak today. So I'm going to talk a little bit about what do we do with uveal melanoma once it spreads beyond the eye. Dr. Krema is extremely successful in treating patients with local therapy, but unfortunately, if you develop disease that goes beyond the eye, it's quite a difficult condition to treat. And unfortunately, some series suggest that at some point after treatment, up to 50% of patients with uveal melanoma may have a relapse. When patients relapse, uveal melanoma is very interesting in that it tends to relapse in the liver. 90% of patients who have relapse will have disease involving the liver. And one of the challenges with liver metastases is that it's very easy to miss the fact that you have a liver metastasis, because the liver can hide disease for a prolonged period of time. And then unfortunately, uveal melanoma, like cutaneous melanoma, is not a disease that is particularly sensitive to chemotherapy. And up until recently, there have been very few options for therapy for patients. This is the Princess Margaret experience in terms of survival in patients seen in our clinic. As you can see, on the bottom line is time, and then on the bar on the side is the percentage of patients that are alive. And as time goes along, within a year, half of patients have passed away from the time that they're diagnosed with uveal melanoma. Hopefully, we're going to be able to shift these curves forward. Now, uveal melanoma is a very interesting disease in that it has a unique genetic basis. And as Dr. Krema mentioned, there are unique chromosomal abnormalities, but also uveal melanoma has abnormalities in proteins called GNA11 and GNAQ. These are proteins that couple with signaling that occurs on the cell membrane and are involved in sending a signal to the cell to grow. And the GNAQ and 11 mutations have historically been very difficult to target, whereas BRAF mutations that are present in cutaneous melanoma are more easily targeted. The point of this complicated slide is that there are multiple pathways, as you can see here, that are signaling to the cell to grow. And these are all pathways that are being caused by these GNA11 and GNAQ mutations. In terms of clinical trials and strategies, there are adjuvant studies or treatments that are being given to patients after they've had their local therapy completed to try to prevent disease from recurring. Currently, we don't have any of these studies open in Canada, but there are studies that are ongoing in Europe and in the United States. And hopefully these results, which will point us in a direction of something that can be done for patients in the future. This includes approaches such as chemotherapy, targeted therapy, or immunotherapy. There are also several clinical studies that are ongoing in for patients with metastatic disease. Many of these studies are occurring in phase 1 clinics looking at novel agents to try to target the molecular changes that occur in uveal melanoma. There are also studies that are looking at immunotherapies that work very effectively with patients with cutaneous melanoma, and I'll talk a little bit more about that work in a few minutes. There are also studies looking at liver-directed therapy. As I mentioned, 90% of patients will present with disease in the liver, and most of those patients will have disease that's limited just to the liver. Patients who receive either surgery or liver-directed therapy tend to do the best, so that is an approach that can be pursued if a patient presents with disease that's limited to the liver. This is just a recent article that was published in Scientific Signaling. This is a study that suggests that perhaps that mutation, the set of mutations that are very common in uveal melanoma with GNA11, GNAQ, might be targetable. In the past, this has been felt to not be a area that can be targeted with medicines, but currently in the basic science world, there's been very promising data that maybe we'll be able to develop drugs for treating patients with targeted agents. Now, the tumor microenvironment is very complex, so this is basically a figure to say, yeah, it's really complex. There are many different types of cells that make up the tumor, not only the tumor cells, but also immune cells. Some of the immune cells will help the tumor to survive, and other immune cells will fight against the tumor. So the purpose of immunotherapy is to try to develop an immune response that can fight the cancer. When you look at the concept of immunotherapy, it's based on the fact that tumor cells have little aspects or areas or proteins that can be taken up by the immune system and then recognized by the immune system as a target. And then these T cells are able to target or travel back to the tumor and kill the target tumor cells. The concept of immunotherapy that's gotten a lot of press recently, and also successful drugs being developed, are drugs which target the immune checkpoints of the immune system. Basically, an immune checkpoint is the brakes of the immune system, and the drugs that are currently being used in the clinic are antibody drugs which are able to block these checkpoints and allow the immune system to effectively kill the target tumor. In terms of uveal melanoma, the drugs that are currently approved are nivolumab and pembrolizumab. In cutaneous melanoma, the response rates are around 45% for these drugs. Unfortunately, for uveal melanoma, about 1 in 20 patients will have a response, and this has been shown in several retrospective and prospective studies. While the results are disappointing in comparison to other diseases, this still is a tolerable therapy that for some patients can result in very meaningful results. Now, there's also a combination approach with a drug called ipilimumab and nivolumab. This is currently being used in Canada, North America, and Europe. And there have been some very dramatic responses that have been seen with these drugs, but still the response rate appears to be fairly low in the 14 to 12% range. However, again, if some significant benefit for some patients can be achieved, and we certainly have seen patients benefit from both of these types of immunotherapy drugs. Now, there's a lot of research that's ongoing with other immune checkpoints, and this is just an example of the types of targets that are being investigated, including blocking antibodies for immune inhibitory receptors as well as activating receptors. In North America and Europe, currently there are many clinical trials looking at combination approaches. One of the challenges for uveal melanoma is that often uveal melanoma is excluded, but not in all clinical trials. In any case, the combination combination therapy trials, often for patients with uveal melanoma, we need to look at phase 1 clinical trials in phase 1 groups to access these experimental therapies. Now, one of the challenges with uveal melanoma is felt that probably one of the issues has to do with the immune response. In patients who have a baseline immune response, like in cutaneous melanoma, single agent nivolumab or pembrolizumab is very effective for many of these patients. Combination therapy, however, may be required in tumors that have poor immune responses present within the tumor. Another approach for trying to deal with poor immune responses is to engineer or expand the T cells that are present in the tumor and then target those against the tumor as a therapy. One approach is tumor-infiltrating lymphocytes. There has been a group in the National Cancer Institute in Washington, D.C., which has shown that in uveal melanoma, you can induce clinical responses in the 30% range in patients. Our own group has been conducting a clinical trial in patients with melanoma where tumor is removed, cells are cultured in vitro for a prolonged period, expanded to large numbers, and infused as a therapy. In this clinical trial, lymphodepleting chemotherapy or chemotherapy to make room for the T cells that are infused is required. We then infuse the TIL cells, and patients receive a medicine called IL-2 to help support the immune response. In our own clinical trial here, we treated a total of 12 patients. Most of the patients had cutaneous, one patient had uveal melanoma, and we were able to see clinical responses in these patients. One of the challenges, however, is that for some patients who had an initial, you can see this mass here shrunk with treatment, but then a month after that, the patient developed a new spot that was removed. We found that PD-1 was highly expressed on this patient's tumor, infiltrating lymphocytes. So now we're conducting a clinical trial where patients who've received immunotherapy but then had progression are receiving tumor-infiltrating lymphocytes followed by IL-2, and then we continue with the anti-PD-1 therapy after infusion. And this clinical trial is open to all patients with metastatic melanoma, including uveal patients. We've treated 2 uveal patients on this clinical trial so far. In terms of the uveal melanoma, there are other approaches. One of the challenging issues with uveal melanoma is that because there are fewer mutations present, since it's not a ultraviolet radiation caused disease, there appears to be a weaker immune response against uveal melanoma, and that might explain the lower response rates to immunotherapy. However, the uveal melanoma does have pigment genes that are often seen by the immune system, and therefore there are approaches that can possibly redirect immune responses against the tumor. Now, this is a little bit complicated. I've got 2 versions of this slide. This is the sciencey one. This is the one, and it explains that patients, when you make proteins in the cell, it gets chopped up by a group of proteins that are assembled or called the proteasome. Then those peptides are loaded onto onto molecules called MHC molecules that are presented on the cell surface so that T cells can recognize the target cell. And this is a cartoon that explains this in a little bit more easy to understand graphics. So this blue thing is a cell. Inside the cell, there are proteins. The proteasome chops up the proteins into little bits of proteins that are then presented by HLA molecules or MHC molecules, which are these little kind of waiters that are seen on the surface. And a T cell only is able to recognize its target based on what is presented in these plates by the HLA molecules. Now, the reason why this is relevant is because a very exciting new drug has been designed and is showing promise in the clinic, but you have to have the right type of waiter or HLA molecule in order to participate in that clinical trial. And this agent is a bispecific molecule called an MTAC by a company called Immunocore. This is a molecule that has a T cell receptor element coupled with a molecule which is able to bind to T cells. So the T cell receptor recognizes the tumor, and then with one end, and then the other end it recognizes T cells, and whether the T cell recognizes flu or some other type of molecule, it can be excited by this drug and result in redirecting the T cell to recognize the cancer cell. And here's a cartoon that shows what happens when you infuse this drug. This drug is given intravenously and then spreads out and enters into the tumor microenvironment. The drug will bind to the tumor at the HLA molecule presenting a melanoma peptide, and then it excites the tumor, the T cell, which then results in the secretion of cytokines that can ultimately kill the target tumor cell. And this is an example of the drug that's currently being studied. It recognizes a melanoma antigen called GP100. In a clinical trial that has shown some results that are very promising that we're really excited about, patients that were put onto the study included patients with all types of melanoma as well as uveal melanoma, and there were various inclusion-exclusion criteria that patients had to meet. In the study, there was a dose escalation, so they looked at several doses to identify what was the safest dose. It ultimately was decided that the best way to treat patients was to start with a low dose and ramp up to 68 micrograms. This requires several weeks of infusion, because when you started with a high dose at the very beginning, you had too many side effects. The types of side effects that were experienced were itching, fatigue, fever, and actually a fair number of patients had low blood pressure. And this is caused by the excitation of the T cells that release cytokines that cause the fever and the low blood pressure. What was exciting also to see is that these severe side effects, which did occur in a fair number of patients at the beginning, diminished over time so that it became very tolerable with infusions. And we were very excited to see a large number of patients with stable disease or shrinkage of tumor. Several patients have, even these patients who have minor responses but overall stable disease, have remained on treatment for many, many months, and we think that this is benefiting them. So this is a survival curve that for the first few patients that were treated on were treated on this study. And if you recall, the survival curve at Princess Margaret was showing patients survival down to this range as opposed to in the 75% range after 2 years of therapy. So we're very excited about this protocol. We recently completed a phase 2 study with second line. Currently, Edmonton and Princess Margaret are putting patients onto the protocol. It's a first-line study where patients are randomized to standard of care or this clinical trial. So in summary, uveal melanoma is a challenging disease with, unfortunately, historically low response rates. However, there's a lot of promise and excitement about new drugs that are being developed, and we're hopeful for the future. Thanks very much.
Thank you, Dr. Butler. Please welcome Jaime Jessen. Jaime Jessen has obtained her Bachelor's in Science in Biology from York University and a Master's in Science in Genetic Counseling from Newcastle University in Australia. Jaime has earned certification from both the Canadian Association of Genetic Counselors and the American Board of Genetic Counseling. Jaime has 13 years experience as a clinical genetic counselor providing patients and families with information they require to make informed decisions. Jaime is the medical science liaison at Impact Genetics and is a valuable resource to both healthcare providers and patients. Jaime's passion for patient support and specialized medical knowledge complements the high-quality genetic testing services offered by Impact Genetics. Welcome, Jaime.
Thank you very much. It's an absolute honor to be here. And as a disclosure, I am a full-time salaried employee of Impact Genetics. So I'm going to go over, I think it'll actually nicely complement Dr. Krema and Dr. Butler's presentation and go through a little bit back to the basics of genetics, the tumor genetics of uveal melanoma and the prognosis, and a little bit about BAP1 syndrome, which is something that is quite unique to this, this type of cancer. So I just thought it would be good to sort of have a quick review before we go into our questions. So I think it's important to remember that all cancer is genetic. It is an accumulation of genetic mistakes within a healthy cell that it becomes out of control and becomes a malignant or a tumor growth. And you can see that while the majority of cancer is considered to be sporadic, so these mutations are accumulated over time by chance, there is a small percentage of cancer that is what we call hereditary cancer. So those are the cancers where we know there is a gene mutation in every cell of the body that would predispose people to certain types of cancer. And uveal melanoma generally falls very much into this sporadic group, while there is a small percentage that may have a hereditary cancer condition predisposing them. So that's why I thought I'd go over both today, so it's a little bit clearer for everyone. And so you have to remember, our bodies are made of trillions of cells. Inside each cell of our body, we have a copy of our genetic information. And our tumor cells are no different. They also contain the original genetic information that came from our healthy cells. So when I talk about genetics, you talk about the fact that cells are the building blocks of our life, and they're involved in every process in keeping us healthy. And this deoxyribonucleic acid, or DNA, is really the code that tells our bodies how to grow, function, and reproduce. It's made out of 4 proteins. There are four sort of unique codes that we basically say A, T, C, and G. If you see those codes, you're basically referring to a DNA code. So this just shows you here that the chromosomes inside each cell of our body, if you unravel them, you can see that it's actually made up of tightly wound up DNA, which is basically going to give the code for our bodies to be healthy. So just as a review, as Dr. Krema said, we each have 2 copies of each chromosome. One we get from our mother, one we get from our father. Males and females are the same, other than that last chromosome. Females have 2 X's, and a male has an X and a Y. So when we talk about disomy and monosomy, disomy meaning 2, back to our Latin here, is talking about the fact that each egg and each sperm will have 23 chromosomes which come together so that each baby is equally half mom and half dad. That's a healthy amount of chromosomes that you would expect to see. This is a picture of chromosome 3. So this is showing you just how large that chromosome is when you unwind it and how many genes are actually on that chromosome. And each gene is very important and has its own job. And so you can see that a loss or extra of a piece of a chromosome can contain a lot of information that keeps us healthy. So genes have one job, basically. That DNA encodes a protein called RNA, which makes the protein. The protein is what keeps us healthy. So if there is a disruption in this code, then that protein is thought to be not being used as well as it should be and can result in disease such as cancer. And as Dr. Butler and Dr. Krema alluded to, normal cell division, we naturally will make mistakes in the DNA replication, but there are genes that are there to watch that those mutated cells are controlled. When you have a mutation and that is not corrected, then the accumulation of these mutations builds up and develops a tumor. So you can see here that uveal melanoma tumors, Dr. Butler said, are very unique. And if you can see, this is a picture of a breast cancer cell that has mutated and accumulated lots and lots of copy number chromosome alterations. Uveal melanoma, we're really focused on the 4 chromosomes, 1, 3, 6, and 8, that tend to be changed, as opposed to something like a breast cancer cell where you've got a large degree of phenotypic variability. So this is a simplistic diagram of what the implications of these chromosome changes have in terms of risk of metastasis. And so we can know from our data that it can be a combination of 1, 2, 3, or 4 of all of these chromosomes that can be changed. The loss of one chromosome 3 and the gain of a part of chromosome 8 seems to have the highest risk for metastasis, followed up by a cell that has monosomy 3 or 1 copy, followed up by an 8q gain, and then a 6q gain. So this is just giving you an idea of the implications of the chromosome changes on metastasis. And I think it's important to remember too that, as we said, tumors grow, and Dr. Butler said they're made up a lot of different types of cells. And we call this heterogeneous, meaning that some of these cells can have additional mutations, while some others do not, that are right beside each other. So if you think, perhaps if you grab this cell, you'll see a disomy 3 result, whereas if you grab another cell that might be right beside it, you may see monosomy 3, which is a good example of Dr. Krema's patient that had the same tumor characteristics, but different genetic findings. The genetic changes that we've been talking about that are sort of leading these trials, these are point mutations within the genes that are in the chromosomes. And again, these are not inherited changes. These typically happen just by chance. And we know the implications of some of these changes are important when you consider follow-up and surveillance for high-risk patients. You can see that a good majority of uveal melanoma tumors will have a mutation in one of the 4 genes or more than one of the 4 genes. There is a portion of melanoma patients that do not have mutations within these genes, but it is indeed a uveal melanoma tumor. And we found that through our own data that definitely does exist. But this certainly can give you a good indication of the prevalence of those mutations. So in terms of determining your risk, and I think Dr. Krema pointed out, it's important to consider multiple. You're not considering just the genetics or just the size or just the age of the patient, but many publications have shown that multivariate analysis, meaning including the demographics of the patient, the genetics of the tumor, combined with the histology and tumor size, can give you the most accurate survivorship prediction. And that's something that I think lies in the power of a test like this. So we talked about individual survivorship predictions, and that's using a tool called the Lumpo tool, and it was developed in Liverpool. And what it does is it incorporates the age of the patient, the gender, the size of the tumor, and the chromosome status of the tumor. And by putting all of those pieces together, an individualized survivorship prediction is made. At the moment, chromosome 3 is in this algorithm. The next version will include chromosome 8. And that should be coming up later this year. The Liverpool group is in the finishing stages of the validation, and that could perhaps give you even a little bit more specific individualized prediction based on whether you have both chromosome abnormalities in your tumor. So the way that we typically report this is an example of a very large tumor that's exhibiting chromosome 3 loss and 8q gain. What we do is we give the patient a survivorship prediction typically within a range. The algorithm actually only works when you have a type of cell present or not present. And because of the methods that are used for treatment, we often don't have enough DNA to determine whether there are epithelioid cells or not. So this is given to you as a range because we run it as if they are there and as if they're not. And that's compared to the control group in an age-sex matched group. And this is not 100%. This is giving you an idea of your personalized risk. And I think it's important to always remember that this is not 100% perfect science. Small uveal melanoma tumors with chromosome changes or without can metastasize. Large uveal melanoma tumors without chromosome changes don't metastasize. So it's definitely up to your ocular and medical oncology professionals to guide your management based on all the components. So I wanted to talk quickly about BAP1 syndrome and to sort of highlight the fact that this two-hit theory of cancer is very relevant for this type of cancer. The majority of people that get cancer start with 2 healthy chromosomes. They obtain a mistake in one of the other chromosomes, and the other is hit later, and they develop cancer. Hereditary patients are actually born with a mutation in one of the genes that's there to help us protect us from developing cancer. And they really need to just acquire the second mutation to develop cancer. So these are what we call hereditary cancers. Angelina Jolie and BRCA1 is an example of that. So the BAP1 tumor predisposition syndrome, or BAP-TPDS, is a rare genetic syndrome, again, probably about 5 to 10% of this population, that typically are patients that are presenting with uveal melanoma at an early age of diagnosis. They may have additional cancers in themselves or their family, typically other patients with uveal melanoma, kidney cancer, mesothelioma, and cutaneous melanoma. Breast cancer has also been one of the differentials, or if there's multiple uveal melanomas in the same patient. This type of inheritance is what we call autosomal dominant. So there's a 50-50 chance for a patient that has this mutation in their germline cells to pass it to each child. This mutation cannot reverse itself. This is something that is inherited, and we are all carriers of genetic condition. All of us have 10 to 12 genes that have mutations in them. So it can happen one of 2 ways. You either inherit that genetic mutation from one of your parents, or you happen to be the first person in the family to get a mutation in that gene that happened during embryogenesis. So they call those patients de novo patients. These patients do have a 50-50 chance to pass to their own children, but it's not something that was passed along to them by a parent. So this is an example of a family that we may have found a mutation in the BAP1 gene in their germline cells, in their blood cells. And you can see that this family, when we test the other members of the family, these people also have a mutation in one of the copies of their BAP1 gene, which puts them at risk for all of those different cancers and would really encourage them to get additional screening. So you can see this is a picture again that these accumulation of mutations happen over time. The thought is that a germline carrier sort of starts their life already with one of these mutations, and that's why you get an earlier diagnosis. There is screening recommendations for patients that are carriers of a BAP1 germline mutation, and that's something that is being published and being followed by the specialists covering these patients. I just want to thank you and let you know that we do have a couple of resources on our website from patients that have experienced uveal melanoma. This is Joan, one of my first patients, and Dr. Krema's patient, that talked about her experience in genetic testing and why she chose to do that. And some patients choose not to because they would just not like to know. Others, are at a different stage in their life. So I would encourage you to take a look and always talk to your oncologist about those choices.
Thank you, Jaime. Jaime will now be facilitating the question and answer session.
Okay. Thank you, everyone, for your attention and these great questions. I think I'm going to start with 2 questions that are directed for Dr. Butler. Dr. Butler, the first question is, what surveillance protocol do you use for a high-risk uveal melanoma patient, and what type of scan and test, and how often? And how far into the future do you continue to do these scans and tests?
Well, in terms of how far into the future, since patients with uveal melanoma's risk for recurrence never really goes to 0, we are monitoring patients for at least 5, sometimes 10 years, and maybe beyond. that's an area that needs further work in terms of identifying patients that are at zero risk for running into problems. What we do in our practice for someone who is at high risk is to initially scan approximately 3 to 4 months with assessments. And we like to get a baseline CT of the chest, mainly to know that if there is a problem in the future, we can go back and say whether or not a spot on a chest CT is new or old, because many of us have changes in the chest at baseline that are not cancer. But the main modality for monitoring patients in our practice is to use MRIs of the liver. The CT scan is very helpful at identifying disease. It's particularly good at looking at bowels and spaces between organs. But CT of the liver is not the best modality. And ultrasound is useful, but it doesn't pick up really small lesions. So the best modality is an MRI scan of the liver that we use.
Wonderful. And I think you did touch on this, but another question is come up with the immunotherapy and whether it works. Does immunotherapy work for uveal melanoma metastasis? And if yes, what percentage of people does it work for?
Well, it's, as I mentioned, it depends on how you define immunotherapy. So the traditional immunotherapies that are approved, such as the anti-PD-1 drugs, nivolumab or pembrolizumab, or combination treatments with nivolumab and ipilimumab, the response rates are not as high as we want them to be. It's in the 5 to 10% range. However, the patients who do benefit can benefit significantly. We haven't quite worked out who is going to benefit from these treatments and who are not. So if you're looking at your options, and these are the only options that are presented to you, you definitely need to try it because it might work. There's also some very exciting and encouraging observations where patients have received these new immunotherapy drugs like the IMCGB100 and then have had clinical responses with combination immunotherapy after treatment. And that could be because these new drugs are able to excite the immune response against the tumor and then allow the immune checkpoint inhibitors to work more effectively afterwards. In any case, there's a lot of interest in trying to figure out a way to boost the immune response against uveal melanoma, and that's an area of a lot of excitement right now.
Wonderful, thank you. The third question is, I am class 1A via Castle, which is wonderful, but impact genetics tests show monosomy 3 with 8q gain, which is not wonderful. Please explain, if possible, if I am high risk or not. The two reports completely contradict one another.
Well, I think sometimes we see contradiction between results because of what we mentioned as tumor heterogeneity. Not the whole tumor carry the same cells, the same mutations in all cells. So it depends sometimes if you go with your needle into which part of the tumor, you can get different results. That's why in our technique of biopsy, I used to take from 3 or 4 parts of the tumor. I go into 4 cores, 4 passes, trying to lump from different kinds of tumors. So if you take maybe from one area, it might give you a different results than what you take it from a different area. That's the explanation I have.
I would add too that if you've got a sample from 2 parts of the tumor, if one of them is showing monosomy 3, you have definitely there is a high risk cell in there that is showing monosomy 3, and that you would conservatively take whichever worst case scenario result you have and treat accordingly.
Correct.
Would you agree, Dr. Butler?
Mm-hmm.
The fourth question is, I work in an office with 115 employees. We have had 3 employees diagnosed with choroidal melanoma in the last 15 months. What should our office be doing or testing? Everyone is getting their eyes checked. Hopefully there won't be any more. My first question is whether those employees are related. My first question would be about BAP1 syndrome. I think that would be something to rule out or to consider.
I don't know of an environmental factor that predisposes to uveal melanoma.
Yeah.
So I don't know exactly. We know the cases that happened in the United States, the lump of people in the same school.
Mm-hmm.
There might be something that we don't know of yet, but nothing to my mind.
Mm-hmm. I would say if it's something that has happened and these patients might even be distantly related, it could be worthwhile determining that, because people that have BAP1 syndrome may never get cancer. So there may be family members that are there, but I think that's probably the only thing I would additionally recommend. The third question is, the BAP1 gene mutation reversible, and would this eliminate future metastasis of uveal melanoma cancer? Would you say? I'd say from a germline perspective, no, mutations are not corrected, unfortunately.
Yeah, that's an area of genetic manipulation or genetic therapy that isn't yet ready for prime time. Certainly there are approaches that are being investigated, but unfortunately we don't have a therapy to prevent or to reverse that mutation.
Next question. If a patient did the cell biopsy and it proved to have the reoccurring gene, are there any facts where anyone has outlived the term suggested? Dr. Butler?
Well, so I think that the most important, when I read the reports that I get that have these survival curves, the most important thing to understand is that there's always, on any survival curve, there are always some patients that are doing much better than the average. So just because you have an average of 50% of people alive at 1 year does not mean that everyone has passed away at 1 year. A lot of people are going to be just fine. And we have in our clinics lots of examples of patients who are quite remarkable. They are exceptions to the rule, and therefore we need to understand why they're doing so well compared to other patients. But in any case, I don't think any of these reports are death sentences. They're just guides to help us prepare and to be vigilant.
Wonderful. Next question, Dr. Butler. In cutaneous melanoma, I believe recent studies have shown that elderly patients often respond better to immunotherapies. I have also seen the same for melanomas that are more highly mutated. Uveal doesn't seem to have many mutations. Perhaps that is a reason for lack of response, and perhaps needing to find the specific reactive proteins.
Yeah, that is currently one of the theories for why uveal melanoma is less responsive to the immune checkpoint inhibitors. And there's another hypothesis, which is that compared to cutaneous melanoma, the eye is a immunologically silent space as opposed to the skin, which is very active with lots of cells that help to jumpstart an immune response. Additionally, the liver has been found to be a more difficult organ to treat for metastases because the liver also has an immune suppressive environment. So these are all elements that are under consideration and for developing drugs to try to make the treatment more responsive to immunotherapy, or the disease more responsive to immunotherapy.
Right. Perfect. I guess, Dr. Krema, do all patients receive a biopsy procedure before the Reiki treatment is placed on the eye?
Yeah, we try at Princess Margaret to offer it to all the patients as possible. A few exceptions is if the tumor is very small, very shallow, like very unlikely to be of the metastatizing type, and it's located under the fovea, the central part of vision. I think the biopsy might cause more harm to the vision than the radiation treatment of it, and usually those tumors behave well because of the very, very small size of it. But we biopsy tumors as small as 2 millimeters, and we try to offer it to all the patients. Maybe also very elderly patients, because we do not have very good survival data above the age of 80, 85 years. We sort of offer it, and if the patient is hesitant or declined, we do not argue much about it. But yes, we try to offer it for almost every patient.
And I think I would add too that some patients are perhaps uncertain if they'd like to know the information, and there's really one chance to get your biopsy. So I'd always encourage for people that choose to use the impact test, you can take a biopsy and send it to Hold It. Perhaps if that's an option.
Yeah, we have that situation happening several times, is that the main reason the patients decline genetic testing is that they do not want to know.
Yeah.
And we understand that and we respect it.
Mm-hmm.
Still, we categorize them according to the clinical features into low risk or high risk. Mm-hmm. It's not really an individualized categorization, but it's better than not to do anything about it.
Right.
I guess my response is we still don't know if the test has worrisome features. You might do very well and never have a recurrence, mm-hmm. but it does impact, especially in a Canadian environment where we need to be cost conscious, and also it's a pain in the it's very inconvenient to have a scan every few months, and there are lots of trips to the hospital, etc. So if you don't need to have that kind of monitoring, then why do it? So I think that the testing does help us to stratify and to get the right people, the right type of monitoring.
Wonderful. A question, are there any clinical trials for adjuvant therapy for, I think, ciliary body UM?
For systemic therapy, there are, so the answer to the question is that there are adjuvant studies. It wouldn't necessarily exclude patients with a ciliary body involvement. Currently, we don't have any adjuvant uveal studies open in Ontario.
Okay. What is the best treatment modality for a patient that cannot have genetic testing? For example, they have had their eye enucleated before testing became prevalent.
So yeah, we encounter cases like this, had their inoculation a long time ago, and likely they did not develop metastasis. Usually we inoculate large eyes with large tumors. But again, we have the classification of risk based on the clinical findings. So if the tumor was originally a large one involving the ciliary body, or it has eroded through the wall of the eye, all of these are risk features. Also, there are the histology slides, like the inoculated eye we sent for pathology, and we can look at features that have been identified to be associated with risk of metastasis. And we categorize the patient according to that. Is he high risk or low risk? And in that case, he would follow the same way as the patient who had the genetic testing. Mm-hmm. He's high risk, he will be followed by medical oncology, frequent MRIs as necessary. or low risk and followed by us in the ophthalmology clinic.
We were in the IMP GP100 trial for 18 weeks, first treatment after enucleation, but left after lung mets progression. Liver tumor locations were not optimal for TIL, so we chose instead to pursue radioembolization with IPI Nivo immunotherapy meds. Do you have an idea of the percent outcomes based on this current protocol?
Well, there have been a few exciting, so we don't know, I think is the answer. It's too early, certainly in terms of if you received IMC GP100 and then you went on immunotherapy combination, there have been some responses, and that's about as much as we know right now. We don't know percentages.
Next question was, I was diagnosed 3 years ago, treated with brachytherapy, and I'm Castle class 2. The remaining tumor material was sent for additional genetic testing, but was contaminated in the process, so I didn't get any further information. Is there a way now to determine if I have the BAP1 mutation? I would say that the BAP1 mutation, in terms of whether it's a tumor mutation you're looking for or a germline mutation, I think if you have a personal or family history suggestive of an underlying BAP1 mutation, you can certainly consider genetic testing. That is a blood test, so that doesn't have anything to do with your tumor. I would say that if in the case that it may be a tumor test that you're looking for the BAP1 expression, I know oftentimes once that tumor is degraded or perhaps contaminated, or there's not sufficient DNA, unless you need to go back into that eye for another reason, unfortunately, I don't think it would be available to you. Would you agree, Dr. Krema?
No.
Good questions. How long does it take to get the results of the biopsy procedure? Oh, that's okay. And life expectancy percentage. Our turnaround time is between 3 to 6 weeks, typically closer to the 3-week mark. So you've got that well in time for your follow-up appointment with your surgeon or your oncologist. Good. Thank you very much, everyone, for your really good questions.
Yeah, thank you.
So we're now closing the Q&A section, and I'd like to thank all of our participants this evening for joining us and asking those questions, and also our speakers for their time and their valuable insight and medical expertise on this topic. And I hope that you found these presentations to be very informative and useful in your patient journey. Please reach out to the Melanoma Network if you need further information on any of the topics discussed, or you'd like to learn a little bit more about our patient support groups for uveal patients, or would like to obtain free patient resources on uveal melanoma. We can be reached on our website, and that's www.melanomanetwork.ca, or you can email info@melanomanetwork.ca. Thank you again for joining.